this week on the BackTable podcast.
Yes, that's one of the benefits of the fact that we're talking about mobile equipment is it can go to different treatment sites. And so there's no problem with having physician partners that treat their patients at different sites of care, as long as it's possible for the partnership to get contracts with those sites to provide either the shockwave lithotripsy service or at least the laser or sell the consumables. As long as the partnership can get contracts, then there's no problem providing, the partnership's services or equipment or consumables to multiple sites.
Hello everyone, and welcome back to BackTable Urology podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and backtable.com. This is Jose Silva as your host this week, and I'm happy to introduce our guest, Clint Davis. Clint has served as a general counsel of Healthtronics in Austin, Texas, since July 2009. And in that capacity, he has been involved in the formation and management of dozens of urology-owned lithotripsy partnerships and other stone management partnerships. Prior to that, he was general counsel of Endocare, a medical device manufacturer of cryoablation equipment, which is now part of Varian Medical System. Before that role, he was an attorney at a law firm in Boston, LA, and San Diego. Today, we're going to be talking about physician partnership and Stark Law. Clint, welcome back to BackTable.
Thanks so much, Dr. Silva. Great to be with you.
So, Clint, let's start by just some definitions. What is the Stark Law?
The Stark Law is a federal law that is referred to colloquially as the Stark Law after Congressman Pete Stark from California, who was the main sponsor of the original Stark Law, and then also the subsequent amendments. And what the Stark Law does is it prohibits physicians from referring designated health services to entities with which the physician or an immediate family member of the physician has a financial relationship. And the term financial relationship is a critical term in the Stark regulations, and it includes a direct or indirect ownership interest or a direct or indirect compensation arrangement. And one of the categories of designated health services is inpatient and outpatient hospital services. So that brings referrals to a hospital within the scope of the Stark requirements, except for the unique case of shockwave lithotripsy.
Do you know the history behind that? I mean, why lithotripsy or why urologists are different from other physicians?
Yes. So originally, when the Stark Law was first enacted in 1989, the only designated health service was clinical laboratory services. So anything that was done at a hospital that was not within the category of clinical laboratory services was not covered by the Stark Law. In 1993, Congress started debating adding additional categories of designated health services. And they were considering 10 additional categories in addition to clinical laboratory services. And one of the categories that they were discussing was a very broad category for inpatient and outpatient hospital services. And what happened was there was a lithotripsy management company called Lithotripsy Inc. in Fayetteville, North Carolina, which later became part of Healthtronics. And the management of Lithotripsy Inc. had the foresight to work with their outside counsel, an attorney named Greg Smith at the Womble Law Firm, and a congressman in North Carolina, Charlie Rose, to have Greg draft a question for Congressman Rose to ask Congressman Stark on the House floor about did this new category of inpatient and outpatient hospital services include shockwave lithotripsy. And Congressman Rose did do that on August 5th, 1993, and it wound up getting in the congressional record. And that was critical because almost 8 years later, CMS issued the final regulations under Stark II, which was the 1993 version that included all those designated health services that were added. And in that regulation at the beginning of 2001, CMS said that shockwave lithotripsy was within that category of inpatient and outpatient hospital services. And as soon as CMS issued that regulation, two trade groups for urologists, the American Lithotripsy Society and the Urology Society of America, sued HHS saying that the regulation violated the Administrative Procedure Act and was contrary to congressional intent. And that colloquy between Congressman Rose and Congressman Stark became the deciding factor when the federal judge issued his opinion in 2002, where he struck down the regulation as to shockwave lithotripsy, finding that Congress did not intend for shockwave lithotripsy to be a designated health service, even when it was performed in a hospital, because of this clear legislative history.
So essentially, it's all politics.
Yes, it was. Almost 8 years before the regulation came out, this congressional discussion occurred on the House floor, but it was positioned perfectly to be able to give the urologist community later the opportunity to have any attempt to regulate lithotripsy through the Stark Law struck down.
So, according to what you're saying, in the future, we shouldn't have any issues with lithotripsy in the near future, right?
Yes, actually, shockwave lithotripsy, the special status that it has, CMS has acquiesced in that repeatedly. And later, when CMS adopted the equipment lease per click prohibition, which is something I know we'll talk about, CMS issued a frequently asked questions right after that per click prohibition was adopted that confirmed that shockwave lithotripsy service arrangements performed in a hospital were not subject to the per click prohibition.
And back then, all the issues started. Were there partnerships with physicians, or how was the model at that time?
Yes, it was physician partnerships. And at that time, it was often done in these mobile coaches that were semi-trailers that contained the lithotripter and where the procedure would occur, but they would pull up next to hospital facilities. And, since then, the lithotripsy technology has become such that the lithotripters are smaller and more mobile, and so they can be brought into a hospital. And as you know, that's typically now where shockwave lithotripsy is done in an operating room.
You mentioned some of the companies that are out there, like Healthtronics, Fortec, UMS. What's the relationship, and what can they offer?
I can't speak to the specifics of other management companies, but at Healthtronics, we offer a full range of different services for the physician-owned entities that we manage. That includes sourcing of lithotripters, lasers, and consumables from the manufacturers, equipment maintenance and repair services, health system facility and payer contracting, HR and payroll administration and credentialing the RTs and the laser techs, scheduling the cases with the facilities, QA and clinical outcomes data collection and analysis services, billing, collecting, and other revenue cycle services, accounting and finance, tax preparation and filing, providing backup equipment and personnel when it's needed, business development, of course, and regulatory oversight, as well as procuring all the different lines of insurance coverage.
So essentially, as a urologist, you buy some chairs with the company, and you guys take care of everything, and then you receive a quarterly check, something like that?
That's right. Yes. Some of the partnerships are structured so that there are advisory committees or boards on which the physician partners will sit. And so in that capacity, they will have regular board or committee meetings where they get updates from Healthtronics and have the opportunity to get involved on the business side with the management of the partnership.
And I don't know if you can answer this, but in terms of actually doing the investment, do I do it under my name, or can I create a company also and have that company be the investor?
Well, we have seen physicians invest in both ways. Typically, I would say probably 90% of the time, it's individual physicians investing in their own name. But in some cases, physicians may want to hold their ownership interest in a trust that they've created for estate planning purposes, or they may have a legal entity that they use, like an LLC, to hold their investments, and so they might want to hold their partnership ownership in that manner. And in some cases, especially with some of the larger practice groups, the practice group might want the lithotripsy partnership ownership to be held by the practice or by an investment entity that the practice has established to hold that investment. And then the doctors would have the ability to participate in cash distributions indirectly through ownership in that investment entity or the practice group.
And I know you're not a financial advisor, but do you know if there's any benefit or one versus the other in terms of taxes, or really pretty much the same?
Well, I definitely am not a tax advisor.
Right.
I think that there could be some tax benefits to holding the interest in a trust, but I think these other these other ways of holding the interest are not really tax driven. They're more, if it's a large practice group, how does the practice group want their physicians, and how do the physicians in that practice group want to participate in ancillary income opportunities?
And is there any restriction before joining a partnership? Like, I mean, there's something like you are a urologist, but for some reason, is there something that you cannot be a part of a partnership?
No, once a physician is out of residency and begins practicing, there is an opportunity to invest in a partnership. But one thing to keep in mind is that an investment constitutes a offer and sale of securities for purposes of federal and state securities laws. And in order for that to be legal, you have to be able to rely on a private placement exemption for the sale of securities. And at the federal level, there is a safe harbor that the SEC, the Securities and Exchange Commission, has promulgated that is easy to satisfy if all of the investors are accredited investors. And accredited investor means for a physician that the physician needs to meet either an income test or a net worth test. And the income test is you need to have had at least in excess of $200,000 in income or $300,000 with your spouse over the past couple years, and have a reasonable expectation of having that same income in the current year. Or you need to meet the net worth test, which is you need a net worth in excess of $1 million, excluding your principal residence. So sometimes physicians just out of residency will need a couple years to be able to satisfy, one of those requirements.
So you need to at least have worked a year, in essence, not just with the initial contract of the group or whatever you're going to join. That's not good enough.
Or you need to have a spouse who has a lot of income or significant net worth.
So guys, listen to that. Okay. So you mentioned the S-Wall. After the partnership with the S-Wall, has there been other opportunities out there? I know you guys have offered partnership with uroscopies. Can you go into details regarding that?
Yes. So there is an opportunity to invest in ureteroscopy partnerships, but the way that they're regulated is different than the way that shockwave lithotripsy partnerships are regulated. So you have to look at a laser partnership different than a consumables partnership. So the laser partnership is subject to the equipment lease per click prohibition. And that, I mentioned that earlier, and that is something that in 2008, CMS added that to the Stark regulations, and it prohibits per-click payments to physician-owned entities that are leasing either equipment or space from entities where they refer patients to, if any of those payments relate at all to patients that are referred by those physician owners. And so basically that means that if you have let's say, holmium stone treatment laser that's owned by a partnership, then it can provide that laser to an ASC on a per-click basis, because outside of the hospital context, if it's an ASC, it's not subject to the Stark requirements. But if it's in a hospital, the partnership can't provide the laser to the hospital in exchange for a per-click payment. And that just means the hospital can't say, we're going to pay this dollar amount per procedure. And the way that is addressed, the per-click prohibition was finalized in 2008, but at the time, there were a lot of per-click equipment lease partnerships, and CMS recognized that it was going to take some time for hospitals and the physician partnerships to restructure those arrangements before the per-click prohibition became effective. So they gave until October 1st, 2009 for those arrangements to be restructured. And there were two ways that you could restructure the arrangement to comply with the per-click prohibition. One, the first way is you could have the physician-owned laser leasing partnership block lease the laser to a hospital directly. And that means that the hospital would get to use the laser for a specific period of time. You could say 2 days a month or whatever it was, but it needed to be set in advance and in place for a year in exchange for fixed payments instead of per click. And as you might imagine, a lot of hospitals did not want to contract in that way because they didn't want to be paying for lasers that they may not use. They only wanted to pay if they were actually using it. So they wanted the per click. And so the second way that those arrangements could be structured to still comply with the per click prohibition would give the hospitals the benefit of per click, but still comply with the Stark regulations. And that would be for the physician-owned entity to block lease the laser to a non-physician-owned entity. And in our case, it would be a wholly owned subsidiary of Haltronics that has no referring physician ownership. We could block lease the laser from the physician partnership, and then we could contract with the hospital to provide it on a per-click basis, as long as those per-click payments were not going to the physician partnership. So there would be a guaranteed block lease amount that would be set in advance for at least a year. But there is also a history with the per-click prohibition and litigation there too against CMS because of the argument that instituting the per-click prohibition exceeded CMS's authority. So right after the per-click prohibition was announced in the middle of 2008, the Council for Urological Interests, a group referred to as CUI, planned to sue HHS and ultimately did in March 2009 to challenge the per-click prohibition. The lawsuit went up and down the federal court system over jurisdictional issues, but eventually made its way in 2015 to the D.C. Circuit Court of Appeals, which agreed with CUI that CMS's explanation for the per-click prohibition did not make any sense. So the explanation that CMS put in the final rule release in 2008 was self-contradictory and defied logic. So the court struck down that regulation, but in the opinion, the D.C. Circuit basically gave CMS a roadmap for if they wanted to readopt the per-click prohibition, how to do it legally. So the next year, in 2016, CMS did readopt the per-click prohibition so that it became effective again on January 1st, 2017. But that's not the end of the story because at the beginning of 2021, CMS rewrote the Stark regulations in a very significant way, and those became effective at the beginning of 2021. And CMS changed the definitions in a way that inadvertently created a loophole that permitted per-click equipment leases. And CMS later that year noticed that they had done that, and so they immediately proposed new regulations that would close the loophole so that effective January 1st, 2022, we now have the per-click prohibition back in effect. So from January 1st, 2022, it basically put back the state of affairs that existed on October 1st, 2009, where a referring physician-owned equipment leasing entity cannot contract with a hospital to provide the laser on a per-click basis. So that's the laser side.
Okay. So right now, I mean, in terms of the partnership, can a uteroscopy partnership be real in terms of, or just with the equipment? How can you do a partnership then?
Yes, so you can definitely have a laser equipment leasing partnership. You need to, if it's going to be providing the laser at a hospital, you need to comply with the per-click prohibition by either block leasing the equipment directly to the hospital or setting up this two-tier arrangement I mentioned to be able to block lease the equipment to a non-wholly owned or a non-physician-owned entity like a wholly owned subsidiary of your management company, which can then provide the laser on a per-click basis to the hospital. And you can also provide the laser on a per-click basis to a surgery center without any restriction. That's not a problem.
So in the ASC is fine, is the hospital is that it becomes more tricky.
That's right. And there's another requirement that's specific to ureteroscopy partnerships that's important to keep in mind, and that is the Federal Sunshine Act, also referred to as CMS Open Payments. And that was a statute that was included in the Affordable Care Act in 2010. And CMS, eventually, we have adopted regulations implementing the Federal Sunshine Act in 2013. And that requires any manufacturer of pharmaceuticals or medical devices or any distributor of pharmaceuticals or medical devices to not just report physician meals, as I think physicians are aware that meals and research payments and consulting payments have to be reported to CMS every year. But the requirements also make it necessary for any manufacturer or distributor that has physician ownership to report annually who the physician owners are, how much they invested, what their distributions have been for the year, and what the current fair market value of their investment interest is. So for a consumables partnership that's providing items like single-use ureteroscopes and laser fibers and, access sheets or any of the other consumables that could be used in a ureteroscopy procedure, that would be a distributor subject to the Federal Sunshine Act reporting. So what typically makes sense is if you want to have a ureteroscopy partnership, that you would form the laser partnership and keep it separate from the consumables partnership, because the consumables partnership is subject to these special reporting requirements. And that way, it's just the consumables partnership that has to, file those reports every year with CMS open payments.
So you're mentioning about two possible, if you're going to do one case of ureteroscopy, in order to be partnership and have the laser and the ureteroscope create two partnerships?
Yes, you can create two partnerships. They can even have common ownership. But if you put the consumables in the laser partnership, there's no reason you can't do that. You just have to be prepared that what gets reported under the Federal Sunshine Act is going to be the investment in that partnership that includes laser, what your distributions are for everything.
So everything's going to get piled up, the diet, everything, the laser, everything together in the same reporting.
Right.
I had a question regarding other type of partnerships. In terms of per click, for example, anything that is brought to the hospital per click has a potential partnership. Can potentially be as a partner. For example, MRI fusion prostate biopsy. I don't know if you are aware, but a machine is brought to the hospital. Talking about per clicks, if it's in that per click situation, it can be a possible scenario for partnerships.
Yeah, we do have per click MRI fusion partnerships that we manage. And actually I'm glad you mentioned that, Dr. Silva, because one of our MRI fusion partnerships is in New Jersey. And New Jersey is the one state that at the state level, there is a very different law. It's called the Cody Law that imposes requirements that go beyond the federal requirements. So in New Jersey, the per-click prohibition for equipment leases, and that would include providing MRI fusion equipment, applies even outside of the hospital. So even in a surgery center or in an office setting, you can't do per-click in New Jersey.
So in New Jersey, it's just the as well, in terms of partnerships, basically.
Well, no, you can do partnerships, but you need to comply with the per-click prohibition, meaning that they have to just block lease the equipment.
So it will be like everything is a hospital. So the ASC will be like at a hospital, and the office will be like in a hospital.
Exactly, for purposes of what type of payment to the physician-owned entity is permissible.
Let's talk about in terms of investment or return of investment. Can you give us some models as well, ureteroscopy, laser, and MRI fusion?
Yes, once a physician invests in any of these types of partnerships, they start receiving cash distributions along with all the other partners as soon as they're made, whether it's quarterly or monthly or whatever the frequency is. Often it's quarterly. I think that's the most common frequency. And the distributions are made based on percentage ownership at the time of the distribution. And the return on investment is going to really depend on the cash flow of the partnership. And the cash flow, in turn, depends on the procedure volume. What are the contracted rates with the customers, like the hospitals, surgery centers, or payers, if there's any payer contracting, and how quickly those customers pay, because you can't distribute cash if the customers aren't paying. And the cash flow also depends on whether the partnership has debt. So sometimes partnerships will take out loans to purchase the equipment or will finance it through the manufacturers. And then there also might be debt that the partnership has from prior physician redemption. So physicians may retire and be redeemed from the partnership, and typically those can be paid by the partnership over some period of years. So all of those different factors go into figuring out how much cash flow is the partnership likely to generate over the next 12 to 24 months. And that's one thing that if you're considering a partnership, usually the process works so that you will sign a non-disclosure agreement to be able to get basic financial information about the partnership, and maybe work with the partnership management team to look at, well, what are possible distributions and cash flow from the partnership under different reasonable assumptions over the next 12 to 24 months. And then you'd also sign an accredited investor certificate. And if you want to move forward with the investment, then usually the way it works is you would receive a subscription packet that would include all the risk factors of the investment and would include an investor questionnaire to make sure that you're not invested in a competitive partnership, because these typically have non-competes where you can't invest in more than one partnership providing whatever that partnership is providing in a geographic location. And then it will also have a subscription agreement. That's actually the agreement by which the investment is effectuated, where you agree to purchase X% interest in this partnership in exchange for this amount of money. And so you would complete all of those documents, and then it would get countersigned by the partnership, and the investment would be complete, and you would be admitted to the partnership as a partner at that point in time.
And do you guys, I don't have you guys as a partnership, and that's nothing against you. It's just I already had a partnership. But let me ask you regarding if there's multiple urologists that none of them have partnerships, do you try to conglomerate them to join all together? Or if there's a difference between somebody that's in a remote area that is alone, is there a difference?
Yeah, well, typically we will want to have many partners to be able to support the fixed costs of the business, just be able to cover the costs. And the more partners you have and the more case volume, the more cash flow the partnership is able to generate. So if you have just one physician, it's unlikely, that they're going to have enough case volume to make it really worthwhile as far as the covering costs are concerned and what the cash flow of the entity is. And also just one caveat too is if some group wants to form a partnership around one physician, that's pretty risky under the anti-kickback statute. So the OIG has issued different special fraud alerts throughout the years. And in 2013, they issued a special fraud alert that was focused mainly on physician-owned distributorships that sold implants. But in a footnote on the first page of that special fraud alert, the OIG noted that the same principles apply to any physician-owned entity. And one of the things they mentioned in that special fraud alert is that they're really concerned if a partnership has just a very small number of physicians. So it seems like if you just had one physician, and the reason they're concerned is because you have a one-to-one correlation between referrals and the payments, the distributions that are made. So I think in our view, it's really just too risky to form a partnership around one physician. You may have a partnership that had multiple physicians early on in its life, and over time, some of the physicians have retired, and then you wind up with one physician, but that's really a different situation than forming a partnership around one physician.
And in terms of partnership, that doesn't have to do anything with, for example, two urologists that are in different hospitals or different hospital system. As long as they're in the same region, they can be in the same partnership, the same group per se, right?
Yes, that's one of the benefits of the fact that we're talking about mobile equipment is it can go to different treatment sites. And so there's no problem with having physician partners that treat their patients at different sites of care, as long as it's possible for the partnership to get contracts with those sites to provide either the shockwave lithotripsy service or lease the laser or sell the consumables. As long as the partnership can get contracts, then there's no problem providing, the partnership's services or equipment or consumables to multiple sites.
And Clint, you work for Healthtronics, but try to answer this one as biased as possible. In terms of a urologist that right now is looking for a partnership, me as a urologist, what do I have to look when I look into a partnership?
Well, I definitely think that you should do your due diligence and make sure, depending on the type of partnership you're talking about, if it's shockwave lithotripsy, then the regulatory treatment of shockwave lithotripsy, given the unique status that we've talked about, is very, well established and accepted. You need to be a lot more careful if you're talking about a ureteroscopy partnership. Because of the per-click prohibition that applies to laser leasing, and because of the Federal Sunshine Act requirements that apply to any buying and selling of consumables, you should make sure that the partnership complies with those requirements, because if the partnership doesn't comply with the stark per-click prohibition, it puts all of the physician owners at risk, because the physicians, by referring patients to a hospital and not having an exception for that equipment lease, if it's per click, there'd be no exception. That violates the Stark Law, and a violation of the Stark Law puts you at risk of civil monetary penalties. It can also be the predicate for a False Claims Act treble damages case and potential exclusion from participating in federal healthcare programs. And with the consumable part, CMS a couple of years ago sent letters to all of the physicians enrolled in federal programs, reminding them of this Federal Sunshine Act CMS open payments reporting requirement for any physician-owned distributorships, to emphasize the importance of physicians being aware that if they're invested in anything that buys and sells medical products, they need to make sure it's reporting.
And I'm an employed physician for Advent, and I haven't had any issues. But have you heard, or can an institution prohibit you from being part of a partnership?
Yes, they can. An institution, if it, as a matter of policy, it wants to prohibit employed physician ancillary investments, it can certainly try to do that. Now, the backlash from physicians may be such that they may reconsider the policy. But typically, we've found, though, that those hospitals or health systems that prohibit physician ownership in some of these commonly accepted types of partnerships, like shockwave lithotripsy partnership or ureteroscopy partnership, that they usually will not prohibit that. They will allow physicians to continue to hold those ancillary income investments even after they become hospital or health system employees. And in particular, if you're selling your practice to a hospital or health system and becoming an employed physician, that's an opportunity. If you already hold a physician investment, we've seen cases where physicians are successful in their agreements with the hospital or health system and getting confirmation that they can continue either indefinitely to hold the partnership investment or for several years after the closing of the acquisition.
What will happen after that resolution? Let's say if they give you can keep partnership after 5 years, or if somebody, urologist move to another state or whatever, that you guys are not partnership in that there, what happens to that partnership?
If you're forced to divest the partnership interest?
Yeah. For any reason you're moving someplace else. I mean, you stop practicing, for example. What happens there with those chairs and that partnership?
Yes, typically in the partnership agreement, there will be different types of redemption provisions. And in that case, if it's a retirement of a physician or a relocation, those would be the types of redemptions where you would get the fair market value of your interest at that time, at the time that it's redeemed. It may, in order to preserve the cash flow of the partnership may have a couple years under the partnership agreement to pay off the redemption price, but that would be how it would work. And that's different than, say, a physician partner invests in a competitive partnership in violation of the partnership agreement. In that case, the redemption price could be something that's nominal. It's not necessarily fair market value.
Okay, good to know. And Clint, in terms of, going back to you're a lawyer, so going back to when an institution prohibits you from being a partnership, and you already signed a contract and everything, is there something that we as physicians can fight or do something to change that contract?
Well, it really depends on what was negotiated at the time. Was there anything that was said at the time of negotiating the contract about the physician partnership? If in the contract you agree to comply with all institution policies without any exception and the partnership interest was not discussed as part of the contract negotiations or even disclosed to the institution, then you're going to have a difficult time unless you have other physicians who are willing to advocate on your behalf to try to get an exception from the institution policy. But like I said, that's the exception. There's really only one health system that I'm aware of that has a flat-out prohibition, and even that system gave the partners that I'm aware of a couple of years to divest their interest in the partnership.
So don't sign contracts if you cannot do any side investment, because really it is another income that you pay. It's a passive income that you can have at the end of the year. You can go to vacations or whatever you want to do, but it's something extra that you don't expect. So I mean, for me, it's been great. So Clint, thank you for that information. And lastly, we have David Soler. He's the Vice President of Business Development of Healthtronics. Any messages for urologists out there that are scared of becoming a partner?
No, first of all, thank you, Dr. Silva, for having us here. Thanks to BackTable Urology, because it's always educating physicians on things that are important for them, especially as they graduate after residency. And the landscape is changing today. If you look at the latest data and polls out there, the urologists are the most burnt out specialty. And many years ago, it was not like that. So ancillary incomes is more important now than ever. And it's important for the doctors, like you mentioned, to look at those agreements. There's a huge needs of urologists across the nation. The hospitals are willing to negotiate because they want to have you there. And it's important that you discuss this beforehand, before signing anything. The other thing that I want to mention is I've been working for over 2 decades with urologists across US and Latin America. I love this specialty. And it is very important to do the due diligence, like Clint mentioned. It doesn't matter what company you're going to partner with. I'm not here to sell you on my company or our organization, but I'm here to tell you, do the due diligence, ask the right questions, protect yourselves, look at Sunshine Act reporting, the per-click prohibitions, wherever it's mandatory, follow those guidelines so you can focus on what is important, which is the patient. And you partner with a company that can protect your interests and that is compliant with the legal requirements. Again, I thank you for the opportunity once again to educate physicians and new residents into these ancillary income opportunities.
Excellent. So Clint and David, thank you for joining BackTable. Thank you for that information. I mean, really, I learned a lot. I wasn't aware of the background of the ESMO machine. Like I said, I have a partnership with ESMO. Definitely looking into the uteroscopy. So again, thanks for being BackTable.
Thank you, Dr. Silva.
Thanks so much, Dr. Silva.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer. Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.